extend a warm welcome to all of you. Today is the 6th of our national online CMEs. The topic this time is stroke. For those who are joining us for the first time, I'd like to inform them that these CMEs are held regularly on the first Thursday of every month from 8 to 9:30 p.m. Today is indeed a special day for IACM, as not only legends of clinical medicine in India, but the country's top strokeologists have very graciously accepted to be a part of our deliberations in the form of guests of honor, chairpersons, or speakers. I welcome them all on behalf of IACM. With a great sense of pride, I'd like to share that the trinity of National President of IACM, Dr. K.K. Parikh sir, National President of API, Dr. Girish Mathur sir, and Dean, Indian College of Physicians, have blessed us with their presence, and they are our guests of honor tonight. Dr. K.K. Parikh sir, past President API and is the current President of IACM. He is not with us tonight as he's traveling and is currently on a flight right now. But I would be failing in my duty if I do not put on record that he's the brain and soul behind these CMEs. It was his idea and he has executed it brilliantly. Dr. Girish Mathur sir is with tonight. He is our guest of honor. He is the current national president of API, the largest association of physicians in India. He's been actively involved in IACM since its inception almost 30 years back. He's a founder fellow of IACM. He continues to take a keen interest in all activities of IACM and works for its upliftment. I will now request him to bless us with his words of wisdom.
Thank you, Dr. Singh. Good evening, friends. Honorable Dr. K.K. Parikh, President IACM, Dr. M.M. Singh, Founder, Secretary and past President IACM, Dr. Jyotirmay Paul, Dean, Indian College of Physicians, Dr. B.L. Bhardwaj, Vice President IACM, Dr. M.P. Singh, the man behind this whole series of webinars, Dr. Suresh Kashwa, Secretary IACM, Dr. A.K. Gupta, Dr. Rewadi, and all friends. And esteemed faculty of this evening, Dr. Sumit Singh, Dr. Ayush Agrawal, and Dr. Vishal Gupta. I wish to compliment and congratulate Dr. K.K. Parikh for starting this very useful and meaningful online series on subjects of common clinical interest. Today's topic of discussion is highly relevant as stroke is one of the most common neurological emergencies encountered by a practicing physician in his daily clinical practice. And a basic understanding of the approach and diagnosis and treatment of a stroke is of paramount importance. I hope today's discussion and interaction will enlighten us about the crucial aspect of stroke management. I am grateful to Dr. Parikh and Dr. M.P. Singh for inviting me and for giving me the opportunity to interact with my IACM friends. Thank you so much, Dr. M.P. Singh.
Thank you, sir. It's always an honor to have you with us. We always love it when you join our meetings. Thank you, sir, for your words of wisdom. Dr. Jyotirmay Paul is our next guest of honor. He is the current Dean of Indian College of Physicians. He is a council member of West Bengal University of Health Sciences. He was the editor-in-chief of Journal of IMA. He is also the editor of McMaster Textbooks of Medicine South Asian edition. He is with us tonight. Sir, I'd like you to bless us with your words of wisdom.
Thank you, sir, for inviting me to the webinar on a very important topic. This is the topic of interest for all physicians practicing not only in India, across the globe. Dr. K.K. Parikh, President of IACM and also past President of API, past Dean ICP. Dr. A.K. Gupta, past President IACM and teacher of the teachers. My respect, sir, to you. Dr. Suresh Kashwa, Secretary IACM. Dr. N.P. Singh, Treasurer IACM, and all my beloved friends, students, delegates observing today's webinar. I congratulate IACM that you are taking such initiative to upgrade the physicians across India with the different topics of interest. Stroke is one of them. Due to the rise of prevalence of hypertension and diabetes, the management of stroke, incidence of stroke has increased. So the management, it is not possible in country, in India, that every stroke will be managed by the neurologist. Basically, stroke is to be managed by the physicians, because stroke, 99% cases, first time it is received and detected by the physician. So understanding of the stroke management, understanding of the neuroimaging related to stroke, it should be the bread and butter for all the physicians. So I am happy with such initiative, and definitely if I get time in future also, I will be present not only as a guest of honor, also as a delegate, also to be updated of knowledge on stroke management. Thank you. Wish you best success. Thank you.
Thank you, sir. It's a pleasure to have stalwarts like you and bless us with the association. I'd earnestly request you to be a member and help us in building this association further. Thank you, sir.
Yes, sir. Very soon I will send my membership. Very soon.
Thank you, sir. With
Thank you,
these
sir.
words, I'll now ask my co-convener, Dr. Kushwa sir, to introduce the chairpersons for today's evening.
Thank you, MP Singh. Now I introduce my great teacher, Professor M.M. Singh, who is a former director, professor and head of the department, postgraduate department of medicine, SN Medical College, Agra, past president of IACM and founder secretary of IACM, chairman scientific committee API in 1999, vice dean of Indian College of Physicians, member of governing body API, and awarded various oration. Ajanta Lakshmi Oration, National Academy of Medical Sciences, Rabindranath Tagore Oration, prestigious Rabindranath Tagore Oration by Indian College of Physicians, DC Bansal and Mrs. Uma Bansal Oration in IACM, and one of the best teacher of the SN Medical College. Next, I will introduce Dr. B.L. Bachanlal Bharadwaj, who is presently Vice Chancellor of MM University, Ambala, former Principal of Government Medical College, Patiala, and Adesh Medical College, Ambala. He did MD Medicine from Government Medical College, Patiala, and postgraduate diploma in Hospital and Health Management from IGNOU, New Delhi. Published 4 books and more than 50 papers in different journals. Organized 2 national conferences, and guided more than 50 theses for postgraduate students. Presently, he is Vice President of Indian Association of Clinical Medicine. Now, I hand over mic to Professor M.M. Singh and Dr. B.L. Bharadwaj, sir.
Dear friends, first of all, organizers, online CME, IACM, for inviting me to the chairperson for today's CME on a very important issue which every clinician faces in his daily practice, that is stroke. The concept is fast changing, and one has to keep himself updated for treating patients for this period when the role of clinician has become very challenging. Coronary artery disease and cerebrovascular disease both go in parallel. Treatment is first initiated in coronary artery disease, and it is later followed in the cerebrovascular disease. Dual antiplatelet with aspirin and clopidogrel was found very effective in coronary artery disease and then now have been tried in stroke. But there had been some controversies and few benefit in some special circumstances. Now let us hear from expert about single antiplatelet, dual antiplatelet, anticoagulant from Dr. Sumit Singh. Dr. Sumit Singh is presently Chief Neurology and Co-Chief Stroke at Artemis Agrim Institute of Neurosciences, Gurugram. His area of interest, though, had been headache, movement disorder, and neuromuscular immunology. But not only that, Dr. Sumit Singh is a founder member governing council of Headache Society and presently executive member of Indian Academy of Neurology. He is a recipient of various awards and honors, and one of them being the best resident neurology of AIMS. He has co-authored headache management guidelines for the Indian subcontinent. Dr. Sumit Singh is not only sincere in his work, but is also very helpful, and whenever needed, he is very helpful at that time for you or personally or for his patients. I know him since the time he is working at AIMS, and at that time I had an opportunity to chair one of the sessions at Agra on headache. And today, almost after 30 years, I got another opportunity to chair a session on stroke. I welcome you, Dr. Sumit Singh, to give a talk on platelets and anticoagulant and their role in stroke.
Should I start, sir?
Yeah.
So thank you very much for those kind words. Are my slides visible?
They are.
Okay. So I thank the organizers and particularly Dr. MP Singh for giving me this opportunity to speak on this August forum. I've been given this huge topic of single or double antiplatelets or anticoagulants and ischemic stroke, when, why, and how long. This actually is a full conference. This is not only a talk. So I'll try to do as much justice as I can in this particular field. So we know time is brain. Cardiovascular diseases have always been in the forefront of emergencies, but the time of stroke is arriving now. There is no doubt that the importance of a dedicated stroke center cannot be overemphasized. And we are blessed to have one such center at our center. We have Dr. Raj Srinivas, who is an ACE neurologist with a double fellowship in stroke and intervention, who is at the spearhead of this stroke center. We have Dr. Vipul Gupta, who is one of the ACE neurointerventionists of the country, who takes care of the interventional work. And I, being a neurologist, provide the backhand support of a neurologist. So while you can take stroke out of neurology, you cannot take the neurology out of stroke. And therefore, this day-to-day requirement of which antiplatelet, how long and how frequently, when to give anticoagulants, how long, when to start, when to stop. And the requirement for these patients in acute ischemic stroke is extremely important. After acute interventions, or when acute interventions are not possible, or when the time has passed for acute interventions, the primary treatment or secondary prevention of stroke remains of paramount importance, and antiplatelets and anticoagulants, or both, might be needed in such circumstances. The platelets play a pivotal role in the formation of cerebral thrombosis. The drugs which interfere with the platelet function are useful in the prophylaxis for thromboembolic disorders. And these antiplatelet medications, they prevent platelet adhesion and aggregation, which ultimately prevents thrombus formation and propagation. And they therefore provide a mainstay of treatment for the treatment as well as the secondary prevention of an ischemic stroke. Now, this is what actually happens inside the artery, and then where an inactive platelet becomes activated and it gets attached to the endothelium under the influence of thrombin and the ADP. There is a change in the shape of these platelets, and there is secondary generation of thromboxane A2, which provides some procoagulant activities. This is followed by the process of loose aggregation of platelets, and then stabilization, clot formation, and later clot retraction. So this is what is responsible for actually a thrombotic event. And therefore, this entire cycle around this platelet needs to be intervened by given antiplatelets. There are several ways in which we can interact with this cycle of platelet aggregation, activation, and adhesion. The most common ones are the thromboxane inhibitors like aspirin. And then we have the ADP P2Y12 receptor antagonists like ticlopidine, clopidogrel, ticagrelor, and prasugrel. I will not be discussing the other mechanisms of platelet inactivation or antiplatelet activities for the shortage of time and in the interest of continuation of the most commonly prescribed drugs. So the classification of antiplatelet drugs are the thromboxane A2 synthesis inhibitors like aspirin, the thienopyridine derivatives, which are ADP antagonists like clopidogrel, ticlopidine, ticagrelor, and prasugrel. And then there are certain antibodies, which are monoclonal antibodies. Then we also have phosphodiesterase inhibitors like dipyridamole and cilostazol. And then there are some newer antiplatelet drugs, which will always be there in the evolution. Now, aspirin is a COX-1 and thromboxane synthetase blocker, and it causes an irreversible inactivation of these enzymes. There are various doses which have been offered, and right from 50 milligrams per day to 325 milligrams per day of aspirin has been tried in various permutations and combinations in different trials. The most recommended doses are 75 to 150 milligrams, and sometimes we might require loading dose in some particular patients. Now, there have been at least 158 trials which have been evaluated in different meta-analysis, where 3,522 non-fatal and 1,424 fatal strokes were observed after randomization. And the antiplatelet therapy, principally with aspirin, reduced the stroke by about 25%, regardless of whether the patient entered the trial with a prior MRI, stroke, TIA, or other high-risk conditions. Antiplatelet therapy, principally with aspirin, increases the absolute risk of hemorrhage and stroke by about 3 per 10,000 treated patients. So the number needed to treat is very good, and the number needed to harm is extremely low. And in this particular trial, but when this was reviewed, there was a strong evidence for the benefits of aspirin in doses of 160 to 300 milligrams per day, as soon as is practicable in patients with suspected acute ischemic stroke. In view of the potential interaction, those patients who have been recently thrombolized, it's best to start aspirin about 24 or to 48 hours, depending upon the volume of the infarct after the thrombolytic therapy or intervention when, as and when it is required. There was limited evidence of the effect of benefit in patients who had ICH, where it was not ruled out by doing a prior CT. But there was no evidence of net harm in such individuals. So there was previously a recommendation that even if you don't have a CT scan, giving an aspirin might not be a bad idea. But now the treatment of stroke has revolutionized to such an extent that it is practically impossible to have a center where stroke is treated and a CT scan is not available. So probably aspirin, if required and when required, would always be after a CT scan has already been done. If you look at the guidelines, then administration of aspirin is recommended in patients with acute ischemic stroke within 24 to 48 hours after onset. For those treated with IV thrombolytic therapy, administration of aspirin is generally delayed for 24 hours later, but might be considered in the presence of concomitant conditions for which such treatment given in the absence of IV thrombolysis is known to provide substantial benefit, or withholding such treatment is associated with increase of such a risk. Aspirin is not recommended as a substitute for acute stroke treatment in patients who are otherwise eligible for IV thrombolysis or mechanical thrombectomy. And this was recently actually modified to eliminate the wording of acute interventions, which are broadly defined, to specify that aspirin is less effective substitute for the treatment of acute ischemic stroke who are otherwise eligible for thrombolysis or mechanical thrombectomy. The second most commonly prescribed drug for an acute ischemic stroke is clopidogrel, and the largest trial for this evaluation was the Capri trial, where clopidogrel was compared with aspirin alone in close to 19,000 patients with stroke, MI, or peripheral vascular diseases, and they were randomized to receive aspirin 325 milligrams per day or clopidogrel 75 milligrams per day. Clopidogrel had a lower event rate per year as compared to aspirin, which resulted in an overall risk reduction of about 8.7% versus aspirin, and there were no major differences in terms of safety. If you look at this chart, then the efficacy and safety outcomes are clearly visible, where the event rate in aspirin was 11.7 as compared to clopidogrel and aspirin in 8.2% of cases. Among patients with TIA or minor stroke who can be treated within 24 hours after the onset of symptoms, the combination of clopidogrel and aspirin is superior to aspirin alone for reducing the risk of stroke in the first 90 days, and it does not increase the risk of hemorrhage. So the current guidelines is that in a patient with minor stroke, treatment for 21 days with the dual antiplatelet therapy, that is aspirin and clopidogrel, begin within 24 hours can be beneficial for early secondary prevention of stroke for a period of up to 90 days from the symptom onset. So it is advisable to start these patients with double antiplatelets when I will be coming to that. And this period should be at least for a period of 3 weeks, longer or shorter, depending upon an individual patient where it has to be individualized. The Charisma trial was a randomized, double-blinded, placebo-controlled trial of roughly 15,000 patients who had established cerebrovascular disease with multiple risk factors, and all these patients received daily aspirin and were randomized to daily clopidogrel or placebo. The clopidogrel patients had an event rate of 6.8%, and placebo patients had an event rate of 7.3%. So Charisma trial demonstrated that there was no significant long-term benefit when clopidogrel is added to aspirin, and the risk of bleeding were similar, but clopidogrel patients experienced significantly higher rates of moderate bleeding. So therefore, it is advisable that clopidogrel does not need to be continued for more than 3 weeks, except in specific circumstances, which I will come to later. So now the third drugs, which are usually the reserved drugs, are ticlopidine and diaperidamol, and they have been compared alone or in combination with the aspirin. Ticlopidine was found to be slightly more effective than aspirin in secondary prevention of stroke after a minor stroke, but the risk of side effects was higher. And in a European stroke study, aspirin, diaperidamol alone or in combination, was found that deaths from stroke were reduced by 13% when given aspirin alone, 15% when given diaperidamol alone, and 24% when both were given. So these are two reserved drugs where either aspirin is contraindicated or there is a primary resistance to aspirin, or clopidogrel cannot be given. Those are the patients where these alternative antiplatelets might be tried. So third antiplatelet, which is now a new kid on the block, is ticagrelor. And the current recommendation is that ticagrelor is not recommended over aspirin in the acute treatment of patients with minor stroke. Then we come to the second arm of treatment, and that is the anticoagulants. The coagulation occurs through the action of discrete enzyme complexes, which are composed of a vitamin K dependent enzyme and a non-enzyme cofactor. Now, if we look at so if you look at the anticoagulation mechanisms, then there are two types of anticoagulants which might be available: those which are dependent on the vitamin K and those which are not dependent on the vitamin K. So the ones which are working through their antagonism of the vitamin K are the older anticoagulants, and the ones which are independent, they act on either the thrombin pathway or the fibrinogen pathway. These are the newer anticoagulants, and these are rivaroxaban, apixaban, and doxaban. And we all are very familiar with the older anticoagulants, that is the warfarin and the aceconazole. So this is basically the broad classification of all the anticoagulants. They could be parenteral or they could be oral. The parenteral ones which act on the thrombin are usually not used. Those which act on the thrombin and factor 10 are heparin and low molecular weight heparin. The one which acts on the factor 10 alone is fondaparinux. Amongst the oral ones which act on thrombin are dabigatran, and those which act on the factor 8 are rivaroxaban and apixaban, which are ones which are available with us. Now, if you look at the role of anticoagulants in cardioembolic stroke, then injectable heparin comes first. It has got a very limited role in the management of an acute ischemic stroke. Even low molecular weight heparin has a very, very limited role in acute ischemic stroke and should be very selectively used. The few indications where injectable heparin or low molecular weight heparin is recommended in an acute stroke setting are those patients who have a cardioembolic stroke and they have a LA clot. If there is an arterial stroke with the fresh clots which have been formed, which are soft clots which have developed over atherothrombotic plaques, these are the ones where low molecular weight heparin or heparin might be required. In some patients with arterial dissection and strokes, and sometimes we have to give it as an overlap where we are starting the vitamin K dependent anticoagulants in the initial phases. So you give heparin or low molecular weight heparin for some time, and then you overlap with the voltage with the vitamin K associated anticoagulants till their effect comes and the target INR is achieved. So the ones which are the older ones and we are all familiar with are warfarin and acinocumarin. These are all oral anticoagulants. They are vitamin K dependent. The problem with them is that they require a slow titration, and they require a regular follow-up with repeated INR evaluations. They also have a significant drug interactions and require a significant dietary regulation. Therefore, it is not easy to monitor these patients on a regular basis. They are indicated for valvular heart disease who have atrial fibrillation and cardioembolic stroke. So if you look at the use of anticoagulants in the management of an acute ischemic stroke, according to the guidelines, then urgent anticoagulation with the goal of preventing early recurrent stroke, halting neurological worsening, or improving outcomes of an acute ischemic stroke is not recommended for treatment of these patients, and this has got a reasonable amount of evidence supporting it. Dabigatran as a therapy for an acute ischemic stroke without atrial fibrillation has been tried, but this trial did not include too many patients. So currently, for the treatment of an acute ischemic stroke without atrial fibrillation, dabigatran might not be a good option. Now, cardioembolic stroke can be divided into two parts. One which is associated with valvular heart disease, and the second which is not associated with a valvular heart disease. Those patients who have a rheumatic multiple sclerosis, who have prosthetic valve, who have infective endocarditis or amerentic endocarditis are at major risk. Patients who have calcific aortic stenosis, a bicuspid aortic valve, or mitral annular calcification, those patients who have mitral valve prolapse, inflammatory valvulitis are at a minor risk. Amongst the non-valvular heart disease patients, those patients who have left ventricular thrombi, have a prothrombotic state, ischemic heart disease, a ventricular aneurysm, cardiomyopathies, those who have left atrial thrombi, or those who have non-valvular atrial fibrillation or a flutter, or those who have atrial myxoma are at a major risk. And the others which are enumerated on the extreme right side are the ones who have a minor risk. So if you look at the new oral anticoagulants, which are the new kids on the block, then the ones which are available with us are rivaroxaban, apixaban, and dabigatran. The doses of apixaban is 5 milligrams twice a day. And if the patient has got impaired renal clearance, then it is reduced to 2.5 milligrams twice a day, also in patients who are more than 80 years old. Dabigatran is available in doses of 75 milligrams, 110 milligrams, and 150 milligrams. There is no pre-specified dose reduction which is required in a phase 3 trial, but almost always, if the patient is older, we would start treatment with a lower dose of about 110 milligrams twice a day. And if a patient is younger, which is less than 75 years of age, most patients would be receiving 150 milligrams twice a day. Rivaroxaban is to be prescribed in the doses of 20 milligrams per day. Depending upon the renal clearance, the dose might be reduced. So if a patient has atrial fibrillation, then the reduction in the ischemic stroke in atrial fibrillation with warfarin has been found to be outweighing the risk of intracranial bleed. So those patients who have atrial fibrillation, oral anticoagulants which are vitamin K dependent can be tried. The FDA has approved dabigatran, rivaroxaban, and apixaban in patients with non-valvular atrial fibrillation. So if the patient is having rheumatic multiple sclerosis with atrial fibrillation, has a sinus node dysfunction or a sustained flutter, then antithrombotic therapy might be required. If there is a prosthetic valve which is there, if the patient has a biosynthetic aspirin valve, biosynthetic prosthetic valve, then aspirin might be enough after some time, and anticoagulants might not be required. If there is an infective endocarditis, then anticoagulation is contraindicated. And if the patient has a prosthetic valve endocarditis, then anticoagulation is recommended. In patients who have merentic endocarditis, then treatment is directed towards the underlying disorders, and low molecular weight heparin might be required in an acute stage. So these are the current recommendations. If the patient has a mechanical prosthetic valve, has a moderate to severe mitral stenosis of rheumatic origin, then newer anticoagulants are contraindicated. If the patient has a moderate valvular disease of other causes like a degenerative aortic stenosis or a mitral regurgitation, or has a bioprosthetic valve or a valve repair after 3 months postoperative, then NOACs can be tried. There is limited data for the use of NOACs in severe aortic stenosis. It can be tried in patients who have transcatheter aortic valve implantation. In patients who have percutaneous transluminal aortic valvuloplasty, it can be used with caution, and it is acceptable in those patients who have cardioembolic stroke following a hypertrophic cardiomyopathy. So in a nutshell, in a cardioembolic stroke, the acute treatment would be thrombolysis if the patient's INR is less than 1.7. And after the patient has undergone a mechanical thrombectomy, to improve the long-term neurological outcome, the anticoagulations might be required. So in a patient who has got an cardioembolic stroke in the acute phase, we have to give antiplatelets in acute stage, and early anticoagulation is associated with a non-significant reduction in the recurrence of ischemic stroke, but there is no substantial reduction in death and disability. And apart from that, there is an increased risk of bleeding. So after an acute stroke in a patient with cardioembolic origin, anticoagulants are usually started at later stage, when I will come to in the summary of my presentation. So these are the recommendations which are there all over the continent. And this is the one which we follow at our center. And I'm thankful to Dr. Raj, who has provided me with this information. So in the early treatment of transient ischemic attack, the transient symptoms suggestive of a cerebrovascular event, it's considered as a TIA unless the neuroimaging reveals an alternative diagnosis. So the antiplatelet protocol for a transient ischemic attack is to start aspirin at doses of 150 milligrams per day and clopidogrel. We might require a 300 milligram loading dose and a 75 milligram daily dose later on. We usually prescribe these patients on these doses for at least 3 weeks, after which either aspirin or clopidogrel, depending upon the sensitivity of the patient, might be continued. The double antiplatelets are not to be prescribed beyond 3 weeks because it increases the risk of hemorrhage and is not recommended unless there is an indication for such therapy. An antiplatelet in moderate or severe acute ischemic stroke, only single antiplatelet might be required in the doses of 150 milligrams per day. In those patients who have large hemispheric strokes, where you might require a decompression, probably even a lower dose of aspirin might be required. Because if we start the double antiplatelets in such patients and a hemicraniectomy is required, then these patients might have an increased risk of bleeding. So therefore, till it is decided that the patient is out of the risk for hemicraniectomy, low doses of ecosprin is advisable in these patients. If the patient has extracranial large artery atherosclerosis, which is in the tune of 50 to 99%, then ecosprin 300 milligrams followed by 150 milligrams once daily, and clopidogrel 75 milligrams once daily is advisable. In certain patients where there's a poor antigrade flow, clopidogrel 75 milligrams might actually be required twice a day. And this antiplatelet therapy for double antiplatelets in high-grade stenosis should be continued for about 3 months, and then a single antiplatelet might be adequate for such patients. If a patient has an atrial fibrillation, which is non-valvular, the first-line treatment is the novel or the newer anticoagulants like rivaroxaban, apixaban, or dabigatran. The time of initiation depends upon the size or the type of stroke. So if the patient has transient ischemic attack, we can start it on day 1. If a patient has a mild stroke, better start it on day 2. And if there is a moderate stroke, start it on day 3. If there is a severe stroke, then we usually delay the start of NOACs for at least 6 to 7 days. If a patient has a valvular mitral stenosis, and if the mitral stenosis valve area is more than 2 centimeters square, we still can give these patients the novel or the newer anticoagulants. But if the valve area is less than 2 centimeters square, then we give these patients vitamin K associated anticoagulants. And all other patients who have any type of other valvular diseases, then the newer anticoagulants can be there. If the patient has a LA clot, then overlap with unfractionated heparin or low molecular weight heparin, which is followed by the vitamin K associated anticoagulants for 3 months. The target and INR is usually between 2.5 to 3.5, and the INR has to be repeated as and when required till it's stabilized. So this is basically in nutshell the treatment of an acute ischemic stroke, and this is basically an outline to tell you which antiplatelet, what combination, which anticoagulant, when to start, and how long to continue. Thank you very much for your kind attention.
Thank you, Dr. Sumit Singh, for enlightening us on single antiplatelet, double antiplatelet, and role of anticoagulants in various situations of the strokes and the embolic strokes and the various types of the stroke situations. I thank you very much for a very good and illustrative talk. And now I invite
Thank you.
Dr. There are no questions in the chat box. We can take it in the end, and it will be by the moderator. It can be discussed. Now I
Right, sir.
invite Dr. B.L. Bharadwaj to invite the next speaker and the next talk. Over to you, Dr. Bharadwaj.
Dr. Bharadwaj, you're mute, sir. Please unmute yourself. Bharadwaj, sir, please unmute yourself. I think there are some technical issues at Dr. Bharadwaj's end. And before he begins the formal introduction of Ayush Agrawal, I'm happy to inform you that he is an MD medicine from our very own SN Medical College, Agra. He has been. Yes,
Now
sir, he is there now.
I can
Yes, sir.
speak now. Yeah. I'm sorry that there was some problem in this phone. I'm very happy to speak about Dr. Ayush Agrawal. He is associate professor in AIMS, associate professor of neurology. He is DM in neurology and DNB neurology. He is member of National Academy of Medical Sciences and associate FAMS. His publications are 80 PubMed indexed national and international journals. His area of specialization is stroke, neuromuscular disorders, and neuroimmunology. Achievements and awards: he has been the chairperson of Young Neurologist Forum, Indian Academy of Neurology for 22-23. He is an awardee for WSO Future Leaders Program for 22-24, Young Investigation Award by World Stroke Organization in 2018 and then 2022. He has also got ML Sony Award for the Best Outgoing Senior Resident at the Department of Neurology, AIMS, for the year 2019. He also the achiever of Stroke Blogger for Stroke Journal for 2021-23. So I invite Dr. Ayush Agrawal to enlighten us with his topic in neurology.
So before he begins, I'll also like to inform the House that he was the quiz winner of IACM Annual PG Quiz Award when it was held in Agra.
That's wonderful.
Thank you so much, sir, for your kind introduction. Thank you, MP Singh, sir. It is indeed an honor and a privilege to be here, especially in the midst of my teachers, MM Singh, sir, AK Gupta, sir, Sumit Singh, sir. So I'll just share my screen. So are my slides visible?
Yeah.
Yeah. So my topic is the management of acute ischemic stroke in low resource settings. So as we all know, that stroke is defined as an abrupt onset of a neurological deficit, which is attributable to a focal cause, with infarctions attributing to approximately 85% of all strokes. what is alarming to know is that someone has a stroke in every 53 seconds in the world, and there is one death from stroke every 3.3 minutes in the world. So we really need to do something about preventing it as well as treating it. And the trends between 2002 and 2030 show that gradually, as infective disease mortality is coming down, stroke is actually the third leading cause of death in the world after cancers and ischemic heart disease. So there are risk factors of stroke which can be divided into modifiable as well as non-modifiable factors. Out of those modifiable, what I want the House to see is that what I've highlighted that these are the 10 most common modifiable risk factors for stroke. And the interstroke study that was published in Lancet a couple of years ago showed that these 10 risk factors together attributed to 90% of stroke risk. So if we could control these 10 risk factors, which are very easy to modify, like hypertension, diabetes, dyslipidemia, cigarette smoking, alcohol consumption, illicit drug use, lifestyle factors like obesity, oral contraceptive use, and finally cardiac disease, we can actually prevent 90% of strokes. So my talk would be incomplete if I did not talk about the WHO roadmap for stroke care. They divide stroke care into 3 levels, which are minimum, essential, and advanced. And it says that essential stroke care is a must. Like, we should strive to get there, even if we are from a low middle income country or a setting of that stature. So it states that all essential stroke services in the part of imaging, we should be able to provide all stroke patients with a bare minimum of a non-contrast CT head as well as the CT angiography so that we can look at the vessels. Coming to thrombolysis, we should be able to provide them thrombolysis either with alteplase or tenecteplase. Tenecteplase is easier, I'll come to that. And finally, when it comes to endovascular treatment, we should have centers in and around where we can actually refer the patients, which is called the hub and spoke model. If I get a patient who will require thrombectomy and I don't have that available at my place or my center, I should know and have contacts at the nearest center which is doing a thrombectomy so that the patient can immediately be referred there and the thrombectomy suite is ready so that the patient can immediately be taken in. Before we go on to stroke care, we should know how to assess acute stroke patients that come to us. And this is the NIHSS, which is the National Institute of Health Stroke Severity Scale, through which all acute ischemic stroke patients that come to us should be assessed. It is an 11-point assessment scale, which has a severity from 0 to 42. The lesser the score, the lesser severity of the stroke the patient has, whereas higher score indicates a more severe stroke. The assessment points include consciousness, best gaze, visual field, facial paresis, motor arm weakness, motor leg weakness, ataxia, sensory, best language, dysarthria, and extinction. This may seem very exhaustive, but once we get the hang of it, it takes no more than 5 to 6 minutes to do this. Why it is important is that if somebody has a higher stroke severity when we are looking at the patient, let's say that that patient has an NIHSS of 16 or 20, and when we do an imaging and we cannot see an infarct on CT, then it tells us that it is actually like we used to study about stunned myocardiums, where it is not dead and is salvageable, but is still not working. Similarly, it tells us that this tissue is not yet infarcted, but there is a penumbra which is not working right now. And if we thrombolize or do thrombectomy for these patients, we'll be able to salvage it and recover the function which has been lost right now. The other thing that we need to know is how to read acute stroke CT scans, which is done by a score which is known as the aspect score. It is named after the place in Canada where it was discovered, which is Alberta. So it is basically to look at anterior circulation strokes, which divides the perfusion territory of the middle cerebral artery into 10 zones. And it is looked at 2 areas, which is the ganglionic as well as the supraganglionic level. So at the ganglionic level, we look at the caudate, lentiform, internal capsule, and the insula, and the 3 territories of the MCA there, which is M1, M2, M3. And in the supraganglionic levels, we look at 3 territories of the MCA, M4, M5, M6. Every region that shows a hypodensity on CT scan indicative of a stroke, we subtract 1 from the total of 10. So lower the score, the bigger the infarct seen. And anybody who's got an aspects less than 6 traditionally tells you that we cannot thrombolize such a patient. Although now with newer and more advanced imaging technologies, we can possibly take these patients up. But since I'm talking about stroke care in low resource settings, I'll not be talking about that. So as an example, this is a CT scan of a patient which shows a right MCA infarct. You can see that, I'll highlight that, just give me a minute. So we see that, okay, sorry. Yeah. So we see that the caudate is spared, the lentiform is spared, and the internal capsule is spared. However, the insula, M1, M2, and M3 is involved. So only by seeing the ganglionic level, we know that the aspects is at least 6. So I would not thrombolize this patient. So then we come to the thrombolysis checklist. The last seen normal is from the symptom onset is calculated from when the patient was last seen normal. Although now, after the wake up trial was published, we know that most patients who wake up with a stroke have most likely had a stroke very near to the time when they were waking up and possibly may benefit from thrombolysis. But that selection is based on MRI imaging, which might not be available everywhere, as well as the extent trial, which showed that thrombolysis might be safely done in a certain population of patients, even up to 9 hours of symptom onset. So this is something that we've been reading ever since thrombolysis for stroke came in, that the indication is anybody who presents with a stroke within 4.5 hours, and a CT showing a hypodensity that does not involve more than 1/3 of the MCA territory and the age is more than 18 years. However, the contraindications that have been classically taught to us is now a gray area, and anybody whose BP is less than 185 by 110 millimeters of mercury might be taken up for thrombolysis if there are no other issues. What I want everybody here to see is that if a stroke patient comes to us, and although traditionally we've been told that thrombocytopenias and platelet counts less than 50,000 cannot be thrombolized, but we need not actually look at platelet counts if we're not suspecting a bleeding diathesis. If the patient has no history of bleeding in the past or no history that makes you wonder that the patient might have thrombocytopenia, we need not look at that and waste time, and we can directly go ahead and thrombolize. Yes, we need to look at blood sugars because both hypo as well as hyperglycemia can be a stroke mimic, and an ECG to rule out a concomitant MI. But apart from that, anything else is extra and is required only if there are pointers to tell you that this might actually be the case in that patient, like a liver cirrhosis or a chronic kidney disease. As I spoke about it, common mimics include seizure, migraine, metabolic encephalopathies, as well as SOLs. Even an NCC can mimic a stroke. We've all thrombolized mimics of stroke. And the thrombolytics that are available to us are alteplase, which is given as a 10% bolus, and the remaining giving over an infusion with a maximum dose of 90 milligrams. The other being tenecteplase, which is given in a 0.25 milligram per kg bolus with a maximum dose of 25 milligrams. It is unfortunate that the thrombolysis rate in India even today is only 4%. And data has shown that at least 20% of our patients present within the window period for thrombolysis. However, only 1/5 of those patients who are otherwise eligible are thrombolized. When we look at the diagram that I've put on the right, we can see that for every patient who is thrombolized within 4.5 hours, 33 patients out of those 100 gain at least by 1 on the disorder impairment scale. There are more chances of living a disability-free life, and only 3 are harmed. So there is such a huge population that can otherwise be completely asymptomatic or have minimal symptoms, but we miss out on those. And we should strive to bring this 4% to nearly 100% of all patients who present to us, and also improve the number of patients who are presenting within the window period by improving the awareness about the symptoms of stroke. This is something that I want to drive home. Thrombolysis is not as costly as we thought it to be in the past. A CT head, which is non-contrast, costs between 1,000 to 1,500 rupees at most centers today. A CT angiography of the head and neck vessels costs around 5,000 to 7,000. Alteplase was an issue because it comes in 50 milligram vials, and most patients who are even 60 kilograms will require a dose over 50 milligrams. So we require 2 vials, making the cost double. But tenecteplase comes in 20 milligram vials. So even if somebody is 60 to 70 kgs, you require only 1 vial, and that costs around 20 to 25,000. So the cost of thrombolysis is actually only 30,000 per patient. And we are doing such a service to patients who are coming within window period by thrombolizing them because they live a disability-free life, which they would not otherwise. So just a little bit about TWIST trial. Since most trials that looked at thrombolysis in the extended window have used additional technology like CT perfusion or MRIs to look at diffusion perfusion mismatch, this was a trial that was conducted in Norway that enrolled people even within the extended window using only a plain CT scan. They saw patients having severity of symptoms and a CT. If they did not if there was a mismatch, they thrombolized. However, this trial was negative, but it is believed if the selection criteria was a little more stringent, it would have been positive, and we can actually select patients for thrombolysis in the extended window, even by using a plain CT scan. So essential investigations that are required for all patients presenting with an ischemic stroke are a CT head, CT angiography, 2D echocardiography, and a Holter. If AF is documented clinically or by ECG, a Holter is not required. But otherwise, these are 4 investigations that should be done and are available in our settings. Why is this important? Is because secondary prevention that Sumit sir was talking about depends on the classification of the subtype of the stroke. This was initially done on the basis of TOAST classification, which is the oldest classification, which classifies stroke into 4 main types, which is a large vessel disease, small vessel disease, cardioembolism, and other determined causes. And for large vessel disease, anything apart from cardioembolism, we require antiplatelets. It may be single, it may be dual, as Sumit sir spoke about, but cardioembolism requires anticoagulation. And the only way that we can delineate which of these subtypes we're dealing with is via those 4 tests. How is that relevant? So when do we say that somebody's got a large vessel disease? There are 3 things that we need to look at. In the imaging on CT, the size of the infarct should be at least more than 1.5 centimeters. The large vessels are in the anterior circulation are either the internal carotid artery or the M1 MCA. In the posterior circulation is the basilar artery. So either of these vessels should be involved, either occluded or stenosed more than 50%, and the cardiac status should be normal. Cardiac status can be defined as normal if you do not find an arrhythmia on echo, and the 2D on arrhythmia on the Holter, as well as no structural deformity on the echocardiogram. If all of these conditions are met, it's a large vessel disease and you treat accordingly. Whereas if the same criteria are seen, there's a large vessel disease as well as there's a big infarct, but you find a cardiac cause, it is said that this patient was having a cardioembolic stroke and you treat this patient with anticoagulation. This is an example. You see that this patient has a large infarct involving the right hemisphere, and the M1 MCA on the right side is occluded here. When you compare it to the left side, you see that the M1 branches off into the superior and inferior division, whereas this one is occluded. So this would fulfill the criteria for large vessel disease. However, if we do not look at the echo might show us infective endocarditis, might show us a thrombus sitting on top of the mitral wall because of a rheumatic heart. We would give this patient antiplatelets, whereas this patient might actually require anticoagulation. So secondary prevention is completely dependent on the workup that we do, and we can prevent recurrence of stroke if we treat them accurately. Small vessel disease is the complete opposite of large vessel disease, where the infarct size is less than 1.5 centimeters, and there's no major large vessel involvement, and the cardiac status is normal. We give dual antiplatelets for 3 weeks if the patient had a minor stroke or a TIA, whereas single platelet is given otherwise. Other determined causes for stroke include a dissection, Moya-Moya disease, sickle cell anemia, and we treat the cause. Apart from that, we can also do carotid artery stenting or carotid endarterectomy if the stenosis was more than 70%, so that the vessel is opened, which will be spoken about more in detail by the next speaker. And we also give other details, we give other drugs. If the patient is hypertensive, we have to lower the blood pressure. We have to give oral hypoglycemic agents for diabetes. And we have to emphasize the patient to stop using oral tobacco, stop consuming alcohol, and stop smoking, which is very, very important. Again, I would like to talk about cost since we're talking about LMIC settings. A tablet of aspirin costs less than 50 paise in our country as of today. Clopidogrel costs hardly 5 rupees per tablet. Warfarin costs around 2.5 rupees per tablet.
So the cost of therapy using these antiplatelets comes to less than or approximately 100 rupees per month. For aspirin, it is actually 12 rupees per month. So I do not believe that if a patient is adequately treated, we cannot prevent stroke recurrence just because of financial constraints. Thanks to the patent of the newer anticoagulants getting over, drugs like apixaban and dabigatran, which used to cost around 15 to 17,000 rupees per month, now cost around 1,000 to 1,200 rupees per month and are being made by Indian companies. And atorvastatin for dyslipidemia costs around 4 rupees per tablet. So these should be prescribed to every patient that requires them. Supportive care is extremely important. Because the patient is immobilized, we need to give them DVT prophylaxis. Swallow assessment is very important and is done by the GUS test, which I'll be talking about for a couple of slides. Limb physiotherapy and speech therapy are important for regaining lost function. And a lot of stroke patients deal with anxiety and depression post their stroke, and they should also be looked at. Although all of these supportive care measures do not seem as important as acute stroke treatment like thrombolysis or thrombectomies, trials have proven that they are nearly as important, if not more important, in stroke recovery. And the odds ratio of getting good functional outcome if stroke care is provided in a stroke unit, which looks at all of these, is actually 2.1. So GUS test is important because of the simple reason that it showed us how to do swallow assessment post-stroke. First and foremost, before we give anything to the patient to swallow, we have to do an indirect swallowing test where we just look at the patient, whether the patient is alert or not, whether he's able to swallow his saliva and there's no drooling, and whether the patient can cough on his own. If that is fine, the major thing to note, which is often missed, is that semi-solids have been proven to be the most easily swallowed substances in stroke patients. So if we're trying to see if a patient can swallow or not, the first thing to give them is semi-solids and not liquids. If the patient can take semi-solids and does not cough, does not have a change in voice in trying to have semi-solids, we can move to liquids. And if the patient can take liquids as well, we can move on to solids. But we always start with semi-solids. Why this is important is if we do not take care of the nutritional status of the patient, he will continue to be in a catabolic state and is unlikely to make a good recovery from the stroke insult. Anybody, the total score of the GUS test is 20. Anybody with a score of 15 or more can be safely started on semi-solid feeds. A little bit about primary prevention. Tobacco control is a must because if the patient continues to consume oral tobacco or smoke, he is unlikely to improve. The concept of polypill has been started in very low income countries in Africa like Sudan, where a combination is made of all antihypertensives, antidiabetics, and is given to the patients at one point of time so that the drugs are not missed. A new thing that is also coming now is about a sodium restricted diet. Initially, we had a very low sodium salt also that was being brought in the market. Now there's a potassium salt that has also come so that the sodium intake comes down, which will help with the blood pressure control. We can have community education programs. And finally, the last one, which WSO is now trying to bring about, is taking healthcare to the community. It identifies places where people commonly go for routine activities like the barber shops and getting a paramedic there who can measure the blood pressure of people visiting a barber shop or have a glucometer to measure the blood sugar, so that hypertension and diabetes, which are the silent killers that usually come to the fore for the first time when the patient gets admitted with a stroke, are diagnosed earlier and treated so that strokes can actually be prevented. This mnemonic can't be emphasized enough, that be fast. This was WSO's theme for last year as well. If anybody has a sudden loss of balance, sudden loss of vision in one or both eyes, as a drooping of the face, weakness in the arms, and a speech difficulty, immediately please call your nearest hospital and go there because you can have a stroke. And going to the hospital in the same time, this is a patient who presented with an acute stroke, was thrombolized. You can see between the first and the second CTs, there was no stroke seen. The patient made a complete recovery, whereas this patient did not receive thrombolysis, and you see a huge infarct that is developed in the right MCA direction. So my take-home messages are that recanalize whenever possible and feasible for better outcomes. Secondary prevention treatment strategies need to be individualized based on the pathogenesis of the stroke. And aggressive physiotherapy and speech therapy, though often ignored, is equally essential. Thank you very much.
Very good. Thank you, Dr. Ayush Agarwal, for enlightening us with a wonderful presentation. Thank you. I think the question answers will be later. So, Dr. MP Singh, the mic
So
is with you.
we can take the question answers at the end of the deliberations. I'll now request Professor Dr. M.M. Singh to introduce our next speaker, Dr. Vipul Gupta, sir.
The friends, now the next topic which we have to discuss is acute ischemic stroke, early management and intervention. And before I introduce Dr. Vipul Gupta, I'm just reminded of an event in 1960, the late 1960s, where I used to be a registrar in internal medicine, and a tourist came from America, and he had a myocardial infarction. And the only treatment available at that time was a strict bed rest. He was admitted in the hospital, Ascent Medical College, and he was in bed for 6 weeks. That was the time and when we have revolutionized the treatment of coronary artery disease to now, at the earliest hour, with angiography, angioplasty, and stenting. The cerebrovascular disease is following that, and now we also in the cerebrovascular disease, in the stroke, we have multiple interventions are available, and earlier the better. And on this, we have a very pioneer speaker with us, Dr. Vipul Gupta, who is the Director Intervention Surgery and co-director of Stroke Unit. He is one of the pioneers in the neurointerventions in India. He has experience of more than 6,000 therapeutic procedures of aneurysm, AVMs, and various stenosis, acute strokes. And with this, I invite Dr. Vipul Gupta to give us his views on acute ischemic strokes, early management, and intervention. Over to you, Dr. Vipul Gupta.
Thank you. Some problem. Can you see my slides, sir?
Yes.
Yes, sir, they're visible.
All right, thank you. So thanks for the invitation. And actually my job has been made much easier by my previous two speakers who have elaborated on the medical therapy, including the thrombolysis. So why we are talking about is because stroke progresses over a while. You know, in medical colleges, like when I was getting trained, that neuron die within few minutes. That is not so. As you can see in the image, the black denotes the infarct core. And as the hours passes by, it expands. And the green is the penumbra zone, which is what, like Ayush mentioned, a shunt myocardium is equivalent of that. That is the area which decreases with time. So if we can open the blood vessel, restore the blood flow, we can stop this infarct progression. And interestingly, this infarct progression happens over many hours. In some patients, you know, 12 hours, and we have learned over 24 hours as well. And that gives us an opportunity to improve these patients this. And another important point which one has to remember, which I would like you to remember, is that how many neurons die in each minute of acute stroke is close to 2 million cells. So very important part of treatment, whether it was that I used to talk about thrombolysis or I may talk about thrombectomy, is the time. Time is the key. We cannot wait for these patients. And even now, studies have shown that major issue, as Dr. Ayush mentioned, very few percentage of patients doing thrombolysis because of the delay in reference to the appropriate centers. So I will just skip this. And I think, you know, they mentioned acute intervention. So I include a few slides of thrombolysis, which we can skip. And I will go ahead.
मुझे आप वो दे सकती हो वो इसका वो कान में लगाने वाला आवाज नहीं आ रही इसकी.
Okay. So up to 4.5 hours, we can give thrombolysis. I will not go over contraindications and the relative contraindications. The key thing, again, in even terms of thrombolysis, is the time. That, as you can see, number of patients needed to treat to benefit, how it goes up as the time passes by. So even when it is 4.5 hours, one cannot think, okay, let us have time to think because we can give it till 4.5 hours. The earlier one gets the treatment, the better the outcome is all about. And this compares the outcomes, good outcome, when thrombolysis is given within 3 hours versus given to 3 to 4.5 hours. So whether thrombolysis, and I will talk about thrombectomy, time remains the key. And I will just skip these slides because I think thrombolysis has been covered. So I will just go and save time. So, I mean, just to summarize, if the patient time window, there is a deficit as NHSS scale, as Dr. Ayush mentioned, no bleed or not a large infarct. It's very simple nowadays. A lot of relative contraindication one can actually ignore, and patients are suitable for thrombolysis. I will not skip. So what are the issues? Why are we talking about thrombectomy in these patients? The problem is whenever there's a large vessel occlusion, then thrombolysis efficacy is pretty low. Whenever there's IC occlusion, M1 occlusion, vertebrobasal occlusion, and then the time factor, you cannot do it without 4.5 hours. And there is a time to recanalize it takes. Even large vessel occlusion, some people initially felt later on they open up, but by the time they open up, then the tissue is already infarcted. And of course, there are many contraindication thrombolysis as well. And here is just a slide to emphasize that what is the proportion of large vessel occlusion in stroke. So overall, this study says when there are 13.7 million strokes overall, 3.4 million are large vessel occlusion. But when you come to the death and disability, the large vessel occlusions dominate. What we are trying to say is that large vessel occlusion strokes have got very poor outcome. And this is where we can make the biggest difference if we treat them in the right manner. And thankfully, we are the lucky generation in which the treatment has come in. So these were the trials, which are multiple trials, which were published in around 2015 in one go, and which multiple randomized trials in various parts of the world. And they all came very strongly positive for what a procedure is known as mechanical thrombectomy. And that is where this procedure came into mainland. And these were the HSA guidelines which were published that time. Then when the pre-stroke MRS score is 0 to 1, that means patient is pretty intact. And there is a major vessel occlusion of ICA, proximal M1. In selected patients, even of M2, M3 ACA, anterior cerebral arteries, vertebral, basilar, or posterior cerebral arteries, NHSS score more than equal to 6, that means patient has significant deficit. Aspects are more than equal to 6, that means they're not a big infarct. And initial guidelines were up to 6 hours, which I will tell they have changed now. And IV TPA, if you can give it, give it. But don't wait for IV TPA to work. That is another key point in time, that we give IV TPA and we shift them to mechanical thrombectomy anyway. So if I have to summarize, any patient who was previously independent but has a deficit, doesn't have a big infarct, large vessel occlusion, TPA, give TPA, but time is critical, shift them for mechanical thrombectomy. So how do we do it? Why are we talking about thrombectomy? In coronary literature, it is always about stenting. Why? Because brain, most of the occlusions are because of a floating clot which has gone and occluded the artery. So all we need to do is take out the clot. We are talking about thrombectomy. We don't deploy a stent there. What we use is a stent retriever device. What is stent retriever? It's a stent-like device, but which can take it out. So we take a microcatheter, we go across the clot here, which is there seen in dark red, and then we deploy this stent-like device, we attach to a wire, still in the microcatheter. We inflate a balloon guiding catheter. This stent sort of sinks into the clot, and then we take it out. And this was a very efficacious method of doing recanalizing vessel very quickly. Other modifications have come in. Sometimes nowadays we are taking very big tubes. These are very soft catheters, very wide bore, but they are so constructed well that we can navigate through the tortuous arteries into this, and then the clot gets sucked into them, and then we take it out. Or sometimes we combine both the techniques, the aspiration catheter as well as stent retriever. The good news is around 80% of patients we can recanalize very quickly using these techniques. A case like this is a 42-year-old patient, NHSS 17. She was hemiplegic and aphasic. You can see still the MRI shows that the infarct is not too big, but CT angio shows left middle cerebral artery is occluded. This is the right patient in which we have to try to open up the artery very, very soon and not wait for it. This is the angiogram, shows IC occlusion actually in this case. These are the microcatheters. It's pretty easy to cross these clots with a wire. And once we have crossed, we always check whether we are in the normal blood vessel. And then the stent retriever device is just deployed through this microcatheter, and we leave it there for a few minutes for it to sink into the clot. The good news is as soon as the device is deployed, the blood flow to the brain starts, so we can sort of reset the clock. And then we inflate what is known as balloon guiding catheter. Guiding catheter has a balloon over it to take it out. You can see the blood flow has already started even before we are taking it out. Balloon we inflate so that no clot gets broken off, goes into the brain. We can suck everything out and the artery is recanalized. Pretty quick procedure. You can see the stent retriever device with the floating clots which all come out. Small infarct, we stop the infarct in its tracks, and patient made an almost complete recovery. I'm just showing the video because it is absolutely amazing as to how these patients can recover sometimes by the time you finish the procedure and we check and patient is back to normal. Same thing holds true for some of the lucky posterior circulation, which are worse strokes. This patient had a basilar occlusion, small infarct, then we can take up. We have gone through the vertebral artery, and then you do the angiogram, basilar artery is occluded. Again, the same thing, we took an aspiration catheter as well as a stent retriever in this patient. Stent retriever we have crossed, and we're deploying the stent retriever with the aspiration catheter there as well. And then we take everything out together along with the clot. And this artery is completely recanalized. And this is my colleague, Dr. Raj Nivas, who is chief of stroke neurology as well as a neurointerventionist. And he did the procedure, and patient from comatose became normal. Sometimes we have to do stenting as well. Like this patient was an old man, cerebral infarct, vertebrobasilar occlusion was there. And then we went in, we took out the clot, but then we saw there was an underlying stenosis there, which we then placed a stent. So yes, we don't do stenting usually, but sometimes when there is an ICS stenosis during thrombectomy, it doesn't remain open by itself, just by angioplasty, or a vertebrobasilar internal ICS stenosis, then when we do stenting. Otherwise, we like to avoid stenting in acute stroke patient, and this patient as well made quite a dramatic recovery. And this is just to show the benefit of combined therapy, what huge number of patients with large vessel occlusions we can benefit if you treat them with IV TPA combined with mechanical thrombectomy versus only IV TPA. So it's a huge advance in medical field. World over, this procedure has exploded, and everywhere systems are built around that, how we get these patients to the mechanical thrombectomy centers. Again, I mentioned time. So ideally what it should be, ideally we should be giving IV TPA wherever is given. We don't wait, we shift the patient, and the thrombectomy center is already warned, they're coming in and we can do very quickly. This patient was lucky in the sense she's a gynecologist and her son is a neurointerventionist who has been my student. So she had a stroke and he called us, and this patient at 1 p.m. was stroke in their local hospital in Faridabad. This imaging was done at 1:36. We showed a small infarct on the right side, but the right ICA was occluded. And they'd give TPA, they talked to us, we said, just give TPA and transfer to us. Even then, all of that, it took us time, 4:40, but here we were absolutely ready for the patient. So at 4:50, we punctured. Again, the balloon guiding catheter, you can see the ICA was completely occluded in this patient. We deployed the stent retriever with the balloon guiding and we took it out. And by 5:06, the artery was recanalized, and it was such a dramatic recovery. The next day, patient was walking around, and she went back to her work within a week, while this patient will remain hemiplegic for life. And she was at MRS1 at 1 week, independently walking and being independent. Again, the key thing is time. It is very important to build systems where we can do quickly, because as time passes by, the chances of good outcome reduces. So even when 6 hours, and I will talk nowadays, we can do 24 hours. That doesn't mean we wait for them to improve. We have, if you think there's a large vessel occlusion, patient should be referred in the window period to a thrombectomy center. Even old patients can benefit nowadays. This is a 92-year-old with M1-MC occlusion, and in fact wasn't too big. Thankfully, his son was in US and a doctor, so we could talk to him. They quickly approved. The arteries are very tortuous, but again, the neurointervention technology has undergone dramatic change over the last few years. So through all this tortuosity, we could go in, deploy the stent retriever, open the artery quickly. And again, even at that age, it was such a terrible life otherwise. And this patient made, as you can see, he's moving both sides very quickly. So what are we looking for? What do you need to remember? 80 to 90% patients we can open up, 60% or so in the appropriately selected patient, they become independent with time. Complication rate is extremely low. Interestingly, IV TPA doesn't add to the complication. This is very interesting, which is what we are. So routinely we puncture and do the procedures on thrombolysis. I mentioned about time. So these two trials have come with down and diffuse theory, which showed that up to 16 hours or up to 24 hours, one trial showed, and this has become part of the protocols now, part of the guidelines, we can do selected patients. But that doesn't mean every patient, because what will happen if we wait, the chances of that patient being eligible goes down with time. But even at 18, 20 hours, 22 hours, if the patient has severe deficit, small infarct, major vessel occlusion, it is very beneficial to open this patient. This was a young lady, right-sided infarct. The right middle cerebral artery was occluded. And so we went in, opened the artery here with the aspiration catheter, and stopped the infarct on side because the motor cortex was spared. This is a young woman, and which made a complete recovery. So even delayed but that doesn't mean we wait, but that means even selected delayed, we should keep in mind that they can benefit from this procedure. And what about large infarcts? So now newer studies are coming. So if it is so good, why not expand the indications? So recently, a lot of publications have come in. Large infarctions also now they say, even in aspects of 4, 5, 6, it benefits the patient. The chances of benefit are less, but still is better outcome than not trying to do them. In India, we are being careful because we warn our patients because they spend money from their pocket. They look chances of good outcome, but we can give it a try. So still we are being careful about, in the sense, informing the family, but they can benefit. Like this patient had a complete right CCA and IC occlusion and largest infarct, but the motor cortex was spared, right-sided, youngest patient, 63 is not old. And we offered the patient. So the arrow shows the right CCA origin completely occluded. And again, with the modern technology, we recanalize the ICA, CCA brain. Well, it's a clot. Once you take out that clot, the whole artery snaps open. And we could recanalize. And again, this patient as well, within a day in the ICU, and he started moving his left side, which is such a big change. Once they become so much better, they can keep improving for life. So just to summarize, any patient who's independent, has a deficit, not a big infarction, major vessel occlusion, give TPA, and time is critical, up to 24 hours, we can benefit these patients. Just the last part of my talk, and Dr. MP Singh talked to me about indication of carotid stenting. So as I told you, one stenting may be done as, suppose patient has stenosis and clot. We take out the clot, we try to do angioplasty, but if the artery doesn't remain open, then we do stenting. We'll try to avoid stenting in acute stage, even with stenosis, because of slightly more chance of bleeding. Western literature has shown that stenting is safe, but in our Indian circumstance, I think because patients come in late, we have seen more bleeding. We try to do angioplasty and wait. But what about TIA patient who has presented or a minor stroke and has a significant stenosis? Ayush mentioned 70% as a criteria, which is there. Then do we do it? What about asymptomatic? It is more complicated. Also, guideline mentioned 70%. We like to do when it's more than 80%, when there is no good collateral flow, patient is not too old, and the complication risk is low. Then only we take up very selected asymptomatic patients. We also do transcranial Doppler in asymptomatic patients, how the cerebrovascular reserve before deciding for stenting. But symptomatic, which is the major work, more than 70%. Then when to do it, the earlier is better. Previously, some people used to wait for 4 to 6 weeks. Now we know the highest risk of stroke is in first few weeks. So any patient with small DWI lesions, severe stenosis like this will be done soon. And usually within first week, unless there's a floating clot or something, we like to go ahead with the stenting. Is a big infarct, then one has to wait. But as long as small infarct and patient intact, then early stenting is beneficial. Somebody may think, oh, there is a good collateral flow, then we give drugs. What happens is most of this is not hemodynamic strokes. These are embolic. Because platelets are activated at the stenosis, even in spite of the drugs, in spite of good flow, patient can keep throwing embolism. Like this patient, she had a coronary artery stenting some time back, was on double antiplatelets, had a right-sided stroke, IC stenosis, but treated medically, but again had repeated stroke. She had this badly calcified irregular plaque. They will keep throwing clots in spite of medical therapy. We have to open the artery, and so the severe stenosis there, low flow in the brain, and stenting is extremely safe. We have done around 300 procedures now in Artemis, and we analyze our data. The major complication risk is 1% and less. And when for protocols are followed, we use a filter device in these patients. In this patient, a small clot broke off, we captured in the filter device, but believe me, maybe 1% of patients of filter device show actually a clot. It is in quite a safe procedure when done well. Last part is intracranial atherosclerosis. You have to realize in Asian population, 20-25% is ICAT. So number one, always get CT angio or good quality MR angio for your patient so that you also document the patient has intracranial stenosis. These are not the patients we try to stent as a routine. Sample trials showed that not to be done. But if there is a repeat events and severe stenosis, then only on medical therapy repeat event, then only we do it. VIEW trial also showed you have to wait till 7 days after the stroke in intracranial stenosis, and then it is reasonable low complication rate in selected patient. Like this patient, heavy smoker, severe basilar artery stenosis. And the right side image, you will think this is CT angio. This is not a CT angio. How technology is going to want to show to you. This is, you can see the guiding catheter in the basilar. This is an intra-arterial injection and a CT angio-like picture, which we can get in our angiography lab. But you can trace each and every perforator. This is very high resolution CT angio-like picture, but in the DSL lab, we can trace each perforator very, very well. Dr. Ayush also mentioned what we have to plan is like drip and stroke network. That means IV TPA is easily given. and then quickly start the drip and ship this patient to the mothership center where thrombectomy can be undertaken for large vessel stroke. But if it is only a small vessel stroke, then they can be treated at a peripheral center. Last part is a lot of technological advances, not is how to diagnose this patient, right? This is the last part. The artificial intelligence has come in big time into diagnosis of these patients. We have just installed this system in our hospital. So AI can diagnose. AI can also do aspect scoring for you. At night, it is difficult. Best of people, how to diagnose what big infarct, to give thrombolysis or not. AI can do aspect scoring. AI can diagnose major vessel occlusion. And in a few minutes on the apps of all the doctors, one can have the info that there is an acute stroke with a good aspect score and you can do thrombolysis or this been meant for thrombectomy. So just recently installed in our hospital, and we plan to install the same system as part of the agreement to us 4 or 5 network centers. But in world over, we are the first one in North India to do it. World over is becoming a norm to have AI to diagnose this patient right on time. So just want to close my talk by saying that mechanical thrombectomy has become frontline treatment for large vessel occlusion. Carotid stenting in selected patients extremely safe and effective, should be done early if it's a small stroke. And ICAD only selected patients, they will need stenting, otherwise we treat them medically. Thanks a lot.
Thank you, Dr. Vipul Gupta, for enlightening us on such a with such a beautiful and illustrative talk. And one thing which has come to my mind, that we usually said the neurologists, they follow the cardiologist in form of coronary artery disease and cerebrovascular, but you have just highlighted what is the different role. We're not following them. We have got a therapeutic interventions and where the results are much better, and the stenting and all that thing is done only in a relative some procedure. Only the need of the day is to have more and more such center where the patient can be benefited with early intervention. Thank you so much, Dr. Vipul Gupta. And now I hand over the mic to Dr. MP Singh, a moderator of the session, for question answer and further discussion.
Thank you all the speakers for your wonderful deliberations. The house is now open for questions. And before someone asks the question, sir, I'd like to ask that nowadays we get CT or MRI reports. A lot of my physician friends ask me, and that MRI shows chronic small vessel ischemic changes. Patient is a mildly hypertensive. So should he be given secondary prophylaxis with the antiplatelets? The question can be taken up. No.
No, it is not indicated.
Microvascular
ischemic changes are extremely common. But unless the patient has a definite history of a clinical stroke, or there is a presence of a significant large vessel occlusion, or there is a stroke which is in the silent area but is sizable, until that time, a secondary prophylaxis is not required.
Another question, sir, which is commonly asked is, a patient is already on dual antiplatelets, maybe due to a coronary event sometime in the past, and he develops a stroke, and we cannot find any source of an embolus. So what do we do then?
So in such cases, one has to understand that how actively have you looked for cardiomyopathy stroke. What we stop is at a 24-hour hold. But many times these patients will have to be evaluated for other causes of stroke. They have to be worked up for any vasculitic processes. You have to look for a 7-day holter and sometimes even longer duration holder, because many times the silent atrial fibrillation and intermittent atrial fibrillation is seen in as high as about 20% of patients with idiopathic strokes. So one has to work more diligently to look for these disorders. Anybody else would like to add anything more than that?
Are there any other questions? Would anybody else want to ask anything?
There was a question in the chat box about the role of mannitol. So mannitol is given as a sort of a bridging process in those patients who have large strokes, in those patients who have developed a midline shift on CT scans, those who are waiting for hemicraniectomy in serious cases with large strokes. Another option is hypertonic saline. Hypertonic saline has been evaluated recently, and at our center we use more of hypertonic saline rather than mannitol for those patients who have large stroke with significant edema and midline.
Dr. MP, I wanted to ask you a question.
Sure, sir. Please go ahead.
Thanks everyone for a very nice talk and what a really nice topic. Sir, I wanted to drift away from acute ischemic stroke. Recently, I had a patient who had a MCA stroke and right MCA stroke. And on carotid vertebral Doppler, we found that the right vertebral artery was thrombosed. So what should be the plan on this patient? Should we leave them alone, or right MCA, he recovered very well, that was fine. His power was 4+ within 3 days. Now, what should be done for the vertebral artery? Should it be changed or what should be done?
No, if
So
the
if it is
left
complete, sorry.
It's okay. So if the left vertebral artery is fine, if this is not a posterior circulation stroke, and vertebral arteries, you have to realize many times they're normally also hypoplastic. Its absence is rare, but they can be hypoplastic, and Doppler is not a definitive investigation. If the other vertebral artery is fine, then there is no need to worry about it. Even if there is a posterior circulation symptoms and 2 vertebral arteries are there, if one vertebral artery is sizable, is fine, then we treat them only medically. So for your satisfaction, you can always get a CT MR angio done, but I don't think it'll be clinically relevant in this patient. One need not worry about it.
Carotid Doppler is a highly independent,
Yes.
is a highly user-dependent modality. So ideally, more objective tests should be done. So either a CT angiography or a contrast-enhanced MR angiography of the carotid and a cranial vasculature. That is actually an ideal investigation for all those patients who have had any stroke. So a single blocked vertebral artery does not take any change.
I think Sumit has brought a very important point. Believe me, I get patient of carotid stenosis referred to me, and what he has said, 50% of patients with reported as carotid stenosis on Doppler, you do angio. So in fact, I don't take up patients usually on Doppler reports at all, because most radiologists, you have to measure the velocity of the blood to say what degree of diagnosis. They just do cross-sectional measurements. It's not acceptable. So we always get a CT angio or contrast, and MR angio again overestimates until it is with contrast. To be sure before we take up for carotid artery stenting. And same thing for posterior circulation strokes. Doppler is useless because they cannot see vertebral artery origin or intracranial. One should do a good quality CT angio or a contrast-enhanced MR angio. Yeah.
Sir, another question. Another
Yeah,
question is, if we have to choose between the CT angio and a contrast-enhanced MR angio, which one should be used?
Both are good. In our center, I think we prefer CT angio. If the creatinine is fine, then CT angio is pretty good. I mean, it shows up, gives a lot of information, but done well. MR angio problem is how many centers do it very well and report it well. It is also quite good.
Thank you. Thanks.
Good. I would say that in your center, which radiologists are very good at, one of those you get it done.
Sir, if there is bilateral significant internal carotid artery stenosis, maybe to the tune of more than 70% bilateral, and there is a stroke in one of those arterial territories, large stroke. So would you try to do intervention on the other side?
So first of all, we only target in the, see, anyway, bilateral carotid stentings are never done because they can lead to a lot of hemodynamic changes and brain hyperperfusion. So what we would do is we'll take up for a DSA, we'll do the stenting of one side. And believe me,
the affected side or the non-affected side?
Affected side has to be targeted. And believe me, most of these cases on the opposite side, it turned out to be 50-60% stenosis, and we follow them up medically. Until that is a very severe stenosis and there are no good collaterals, then only we think about as a stage second stenting. But I think 80 to 90% patients can handle be medically. One has to also realize, as long, again, the measurements are very important. You have to realize even in CT angio, even in DSA, people over-report a lot. Degree of stenosis. When you do the exact measurement, it is 50, 60, 70%. We can just treat them medically, but keep them on follow-up. Asymptomatic stenosis has got quite low stroke rates on medical therapy. This is what, although our procedure is also extremely safe, but on the other hand, medical therapy is advanced. And asymptomatic stenosis, the stroke rates are very low on optimal medical therapy. I think Ayush and Sumit can always, give their opinion as well.
So another question is, I just want to ask you, patient is on dual antiplatelet. He has got a significant stenosis in one of the internal carotid artery. He developed another infarct, a large infarct. So now we know it's an artery to artery embolism. So should anticoagulant be given in this patient?
So anyway, this is a medical question. So would you, Ayush, you or Sumit?
Ayush or Sumit sir can take it.
I mean,
Ayush, would you like to answer this?
Sir, I would not give anticoagulation. If you said that there is a significant stenosis, I would rather continue dual antiplatelets. And once the stroke is 2 to 3 weeks old, I would want to stent that patient because that takes care of the problem from the root, rather than giving anticoagulation, because there's no proven benefit of anticoagulation in stroke. Especially in intracranial disease, I would be very skeptical in using anticoagulation.
So, what we do, MPC, is that some patients have floating clots in the ICA.
Yeah.
We do the angiogram for stenting. There's a floating clot. So again, maybe antiplatelets are enough. In these selected patients, and when there are not big infarcts, they were already sort of at a right stage to be stented, then we don't do the stent. Either we refer them to endarterectomy or we give them 1 to 2 weeks of heparin as well as aspirin to dissolve that clot. That is one situation where Dr. Sumit also mentioned in dissections and floating clots in ICA, where we give anticoagulant for a short period and then switch back to double antiplatelets and do the stenting, or we can send them to endarterectomy as well.
So only those patients who have a significant stenosis, but over the atherotech plaque, they have overlying soft clot. Only in those cases, injectable short-term anticoagulation might be.
Thank you, sir. Would anybody like to say anything? If not, I'd like to request our President-elect, Dr. H.S. Pathak, sir, who would like to give a brief preview about the annual conference that we'll be having in Agartala, if he's here, sir. Dr. H.S. Pathak, sir, or anybody from his team? I think he is not there. There must have been some network issues. Would anybody else like to say anything before I formally give the vote of thanks?
One query, sir, this is for Dr. Vipul Gupta's lecture.
Yeah, can you hear it? Yeah.
Yeah, this is regarding the Dr. Vipul Gupta's lecture. In the last, he mentioned about the AI associated some app. They might be coming or they are already there. Firstly, that we would like to know. And if they are there, then it is for the MOs or the specialists in the CHCs or the district hospitals to make enhance their decision-making capacity. Can you enlighten on this, Dr. Vipul?
So it's very important. That's why I mentioned it, that this is something which should be more than what it is being used in our country. AI-based softwares are already freely available in our country. Only thing the cost factor is there. It's not so cheap either. So not many centers have installed it. And the good news is that one we have installed is from Indian companies. So a lot of companies are coming up, and therefore the cost can be brought down. And I absolutely agree with you. World over, any stroke center in their networks, they will have this AI system. Because let me tell you, I mean, here in we have a big team. Dr. Smith leads a big neurology team. I have a team of 3 faculty, 3 fellows. Even then, you cannot ensure very quick evaluation of scan, which is needed for these patients, and accuracy. And if somebody is there at night who is not so experienced, and to give or not to give, these are hugely useful. And absolutely, I think government should take actions in all peripheral hospitals. If they're installed very quickly, one can get, and they're quite accurate, not completely, but quite accurate, that which patient we have to move very fast for thrombolysis or which patient one has to transfer for thrombectomy. So there are already available softwares, and world over, it has become mandatory. Every stroke center has these softwares. They don't even think about it. In India, the penetration rate is low, and but hopefully, as the stroke awareness is growing, we'll have more and more centers having these softwares. We have just installed. We have just got ours one operational just a week back.
Can you name, sir, regarding this?
Sorry, I couldn't understand you.
Can you name one or two apps which are you have already installed?
So the one which we are using is an Indian company, Cure AI, but it's like FDA approved and all. Cure AI, but one of the one which is very popular world, who started this all known as Rapid Imaging, is an US company, more costly. And there are many other softwares as well, which are there for this purpose. So they will have like 90-95% accuracy in looking for the major vessel occlusion, which is again, at night at 2 o'clock, and all the doctors will have the app. Like our all neuroscience neurologist and stroke team has the app, and anyone can see quickly. And also when we are tying up with the peripheral center where do thrombolysis, in their center we are installing the same software in their MRI or CT. So in our app we can see, okay, Rohtak ke is hospital mein, acute stroke aaya, but has major vessel occlusion, and they can quickly ask and say, please shift. And we are already prepared with their imaging and everything, and all the data remains in this app. So these are very good for research purposes as well in the longer run, because all the data remains there. So, I mean, so again, AI is coming in big time in everything, including in imaging. And here is something very practically useful.
Thank you.
Thank
Thank you.
Yeah.
Thank you, sir. I would like to thank our guests of honor and chairpersons who took out time from the busy schedule to be with us. It was an absolute honor to have you with us. Dr. Sumit Singh sir, Dr. Vipul Gupta sir, and Ayush deserve special thanks for their excellent deliberations. It is often said, and quite correctly so, that better than 1,000 hours of diligent study is one day spent with a great teacher, and you are such good teachers. It's always a pleasure to be with you, listen to you, and learn from you. And thank you, everyone, those of all who participated in today's CME. It is all possible because of your active participation, which keeps us motivated to have more such CMEs. Thank you, everyone, and good night.
Thank you. Thank you. Good night, everybody.
Thank you, Dave. Good night.
Good night.
Good night. Good night.
Thank you, everyone.